Thank you to the Society, Drs. Lundquist and Feldman. It's always an honor to share a podium with you and be with you again. I'm going to shift a little bit, as Ollie said, all morning today and up until the last couple of presentations, you've heard about the elements and how the elements are used in different types of protocols. Now you may be sitting there with your own questions. I don't think I can do that. My esophagus surgeon would never do that, or my anesthesiologist won't. And at this point, we're going to shift a little bit in the day and start talking about what it takes to actually do this. I've specifically been charged with speaking more loudly, thanks, with talking about how to make your team, how to come to consensus when you have points that may not be as clear for all the members on your team, and also how to approach those obstacles that will come up. I don't have any disclosures that will affect our discussion today. These are my objectives again, and I do want to add to my title that I was given successes, because I think most of the obstacles are actually going to lead us to success. I'd like to give you some definitions as I start. These are just casual definitions. I didn't go to a dictionary. This is my day-to-day work. My team is anyone who participates in patient care, in the care of my patient, and has an interest in their outcome. Consensus tends to come through cooperation, and I'll go into details of that. And the obstacles are really just growing pains. In more detail, anybody who touches one of my patients or cares about the outcome of that patient is somehow involved in my enhanced recovery protocol. As Dr. Young-Fedek said earlier in her presentation, there's no one in the hospital that has something to do with a surgical patient who can't make or break your protocol. So you need to figure out where your patient is, where they're going, and what you want to achieve in that patient journey. Consensus is really cooperation, and it's really however you get the evidence in place and however you can implement the different bits of enhanced recovery to improve that outcome. Whether it's a matter of compromise, whether it's a matter of you learn something and somebody else learns something, or whether it's a matter of doing a trial or trial and error, trying to get something in place. That's how we get it done. And the obstacles are really anything or anyone who stands in the way of your getting that work done, and we'll talk about how to get over those. The essential team members, I can come up with this list, but again, I can tell you that this list is terrifically incomplete. I stand here as a surgeon, so I'll say that we're important. I don't think that any of the enhanced recovery protocols I know about are in place without a surgeon champion at least, and usually a team of surgeons working together. But I also don't know of any successful protocols that are in place without an anesthesiologist on the other side. And I'm lucky enough to have an entire team of anesthesiologists, and most of the successful enhanced recovery protocols that you see literature coming out of will have several surgeons and several anesthesiologists involved. And again, it takes every layer of that. So it is the preoperative anesthesia team, it is the postoperative anesthesia team, it's the acute pain service at our hospital. All of those people are involved. A nurse champion, if you can have an assigned coordinator, it's fantastic. That person can help with auditing. And we have a nurse coordinator who will be talking in just a little bit to say exactly what she accomplishes in her protocol. And then every place you go in the hospital, wherever your patient visits, there's going to be a champion in that area that makes sure the things that you want to accomplish, whether it be getting Foley's out, whether it be walking your patient, getting a diet to them, making sure they understand whether or not they need a bowel prep, assigning the appropriate bowel prep in a pre-op education session. All of those people are part of your team. They need to be involved in educational sessions. You need to update them when the literature is updated. And when you have outcomes, you need to go back and give them feedback as to how their work is helping you. Someone in administration will definitely be interested when you put these things in place. You're going to cause improvements, and they're going to take note of that. And they'll probably come around a little bit later than you want them to. Sometimes administration is the first group in a hospital that takes attention to enhanced recovery, but usually it's the surgeon, the anesthesiologist. Sometimes the patients come and say, hey, are you doing this at your hospital? And then the administrators tend to notice that the costs go down, the length of stay goes down, complications go down, and they're wondering what's happening, and they'll come to find you. At that point, you know they're on your team, and make sure you engage them. Data capture and manager, sometimes that'll go back up to your nurse champion. Occasionally that'll be your fellows or your residents if you happen to be in an academic setting. Sometimes it'll be you and your Excel. But it's your keeping track of what you do and what kind of difference it makes. And then most importantly, in bold at the bottom, I have the patients. I'm sure there'll be some examples as we talk about implementation upcoming. of how the patients are really the ones who make this happen. We can give them the information. We need to be the ones doing the trials and figuring out what makes a difference. But if the patient knows what needs to happen, you can bet they're going to make it happen. If they know that they're supposed to leave the hospital in a couple of days, they're not going to want to hang around longer usually. So engaging the patients, engaging their families, engaging the caregivers who will be involved in their discharge is very important. I love to use this slide. I've expanded it and made it small so many times now it's getting blurry. But this is what I use every time I start a new protocol at Duke, and it's what I've used when I've tried to do my education around Duke. Really thinking about the experience of surgery as being the patient's experience, not mine. I don't go through every step of this with the patient, though I am in some ways in charge of making sure that what I know about from the literature is in place during each of these steps. So I like using this to think about where do I need to be and where are my team members and who do I need to be involved with as far as education and updates and problem solving. I'll stop for just a second from the overall team process and give you an example from Duke. I like to use this slide to teach what exactly we do at Duke at our different stops. And this is pretty similar, I think, at most of the hospitals in the US. We have a surgery clinic where most of this starts. That's where our pre-op education is. We have anesthesia and pre-op screening. Almost all of our patients will go through there. Hopefully they're getting more and more prehabilitation talks as we try to do more enhanced recovery principle there. We have preoperative holding, we have the OR. We do not have a high dependency unit. This is a European slide. We have a PACU that patients fly through in about an hour and a half. So we don't have a place where they can really be managed by anesthesia post-op. They end up out on the ward and they're managed by our surgical interns. And then whether they go home or need care afterwards. This seems fairly straightforward, and I took from this the same way that Dr. Young-Fadok did. Here are the places I need to be. Here are the people I need to know. I tried to put everything in place. And then we actually got our protocol in place, and I learned the reality of my hospital. This is really what Duke looks like. These are all the people all over the place in the hospital that have something to do with that patient around the time of surgery. All of these people are involved in educating the patient, giving them directions, telling them something about where they're supposed to be. And just as a specific example, I would point out the night before call. The night before call, I didn't know was anything that happened in my hospital. This is a secret nurse who, after she finishes sending out all the patients into the operating room, sits down with the operating room schedule list for the next day and starts calling patients. I thought that that was a hey, show up at 6:30, hey, show up at 9:30 kind of call. That call includes, did you take your bowel prep? Oh, you didn't? Your case might be canceled. Oh, don't eat or drink anything after midnight. Absolutely not. So the first day of our protocol, in February 2010, I counted, I had 27 pages from this person alone who I never knew existed before that day, asking me, what in the world's going on with your patients? All of a sudden, they're not bowel prepped, and you have this special drink they're supposed to be taking. So make sure that you realize everybody that's going to be giving your patient information, or when you find out that patients are confused, try to figure out who told them what, because you'll be able to go through this patient journey and troubleshoot your problems. So overall, just team tips, it's really everyone. And everyone has a common link of improved patient care. It seems like we're walking through a quagmire of people who are always out to get us, right? They want to bowel prep our patients, they want to keep them in PO, they don't want to walk them, they don't want to feed them. It's really not true. We all come to work trying to do the best thing. And if you remember that everybody is there probably trying to improve patient care, then you find common ground. And you say, hey, I know you want this patient to get better. I know that one of the ways is to help them get up and walk today. And if you find that common ground, your team will grow as opposed to have trouble and fall apart. If you always appeal to that interest in better care, you're going to end up with shorter stays and a happier administration in the end. Nurse culture scores tend to go up, work quality scores all tend to go up on units that use enhanced recovery because the nurses actually like it and the patients like it, so they have a better experience. Also, don't forget about your background supporters. Not too sure what else to call this group of people, but there are a lot of people who are very interested in what we're doing who don't really have much of a voice in surgical care. They just do whatever we're told, and the administration believes that we know best, so they just have to keep doing it. but there are pharmacists who would be very interested in evaluating the cost of Interreg relative to the cost savings that you may get if somebody goes home early. There are pharmacists who have helped me give 24 hours of IV Tylenol, even though the administration said it was too expensive. There are nutritionists who are willing to be on the ward to help deliver meals and make sure that patients get what they need. These are patient advocates who can be part of your team, who make your compliance go up so that you get what you want, even though they're getting what they want. And those are the folks you need to grab. Transporters, pre-op attendants, people who can come around and walk, med students who want to volunteer in the summer, anybody around who's interested in doing something, just jump on the common link of improved patient care and your team will grow without really much effort and usually without cost. When we talk about consensus on the team, we're going to carry along that shared vision of improved care. If we carry through a mission to implement all of the elements that you've learned already today because we want to make care better, not because we're trying to be confrontational, usually consensus comes along with it. There's no one leader, there's no one person in charge. This is not an individual sport, but there do tend to be louder voices in the room than others, and often that's the surgeon and the anesthesiologist. When you get a couple of surgeons together and one of them doesn't agree, or someone who doesn't even want to come to the table, how do you deal with it? One of the best ways is to find an impartial participant. One of the great examples I got from visiting McGill was they have a librarian, and she doesn't come in with any particular opinion. She comes in with data, and she says, this is what the data says. You can do it or not in your protocol. I'm not on the patient care side of things. I'm just here to give you the evidence. And the consensus actually can come out of a place of information and a place of trying to build a trial protocol rather than confrontation. Every enhanced recovery team needs diversity of perspective, or it'll never get any better. One of the great things that I've been able to enjoy in getting to know a lot of people through enhanced recovery and through the ERAS Society has been that we don't all know everything about everything. And it's been fun to learn together and figure out what the new protocol should be. How do you do it in the US? How do you do it in Sweden? How do you do it at McGill? Because when we have differences, we actually can find areas for improvement. And that inherently can lead to some conflict, but really coming back to the data is what will probably get you over that. So I say consensus via conflict, if you will, because there will be conflict. There will be people who don't agree with you. There will be people who still insist on doing certain things. And you can use that to fuel a discussion. Let's study it. Let's look at it. We have all of these other elements in place. We can almost do our own controlled study now if you really believe that what you're doing is a better way of doing it, and I don't have any proof in the literature to show you otherwise. And if you do have some proof, you can usually resolve most of those conflicts with data and cooperation and putting it in place. If you don't get to resolve it, you might want to define that problem as an obstacle. I'd say most obstacles regarding enhanced recovery come from the same obstacles that we see in everyday life everywhere. Comes from fear. We think we might blow out that anastomosis if we feed our patient too soon. It comes from beliefs. I was taught this a certain way, and I'm sure it's the right way. One of the fun things for me being back in Utah 10 years after I was here is I realized that every day in enhanced recovery I'm learning something that I didn't really believe I was going to be doing 10 years ago when I went through all of this here. And just sheer ignorance. People just don't know. So if you take the guidelines to somebody and they're like, wow, I didn't know anybody was doing that in pancreas surgery, a lot of times you can get over most of it. Usually the appeal of data is enough. Often, once you have a protocol in place somewhere, administration will be on your side and start fighting this battle for you. I have administration bringing people to me all the time saying, we need this service to do enhanced recovery. Where they've been resistant on their own, they actually have administration now saying, these are at least the elements of enhanced recovery we want you to try because we can see other systems showing improvement with them. Overcoming the obstacles, phone a friend. That's what I did at the beginning. I didn't know what to do. And the advice I usually got, either from the people here on the panel or from other friends, was just relax. It's okay. If they don't do every single bit of it, at least some of it is better than none. And usually that worked. Usually coming around to consensus would happen after we got the rest of it in place. Things tend to calm down and you can bring the data back up and do it again. Make sure you have your data. Once you think something is working, if you can't prove that you've done something at a certain level of compliance, People may not believe you that that's what made the difference. That's particularly important in some of the elements that may cost a little more time or cost some money, like a monitor and anesthesia. So make sure that you're auditing, as you've heard throughout the whole day. And have some administrative support helps a lot. Once you start seeing an improvement, make sure people know about it. Don't let it just be, oh yeah, they're doing a little bit better, or oh, they must be doing more laparoscopy. Take your numbers to administration and say, I'm doing this and this is what happened, and I want you to know about it so that that money can start coming back to your own program. And when all else fails, or as you get started, whichever the case may be, do the easy, free stuff first, because there's a lot of easy, free stuff on enhanced recovery. Getting people out of bed on day 1 is no more expensive than getting people out of bed on day 3. Just do it on day 1. Find out the things that you can do that really don't cost anything and that won't necessarily take any more work. You do those things first, and then you're on your way to getting the rest of it in place. Remember that you don't know everything. So you may be sitting here hearing some of this for the first time today. You may already have some of this in place. You may have been doing it for a year, but that's a year. I may have been doing this for 5 years, but that's just 5 years. 5 years ago, I didn't know this. And when I work with people who don't have this in place yet, I don't necessarily know everything they need for their service. And just because they don't know it yet doesn't make them less than or not as capable. Keeping that in mind as you go through and build your team, particularly as you spread to other services or you try to get an element that's particularly challenging for you in place, just remember, you don't know everything, they don't know everything, and working together will make it work a little bit better. So just in conclusion, your team is everyone who touches your patient, and remember that you all share the mission of improved patient care. Your consensus is going to come out of cooperation and evidence, audit, and share your outcomes. And your obstacles are really just your successes. You just haven't been able to see them yet. Thank you.